My name is Matt Race, and welcome once again to the Race Academy program, episode 25. And what a wonderful year it's been for the Race Academy. We've had some fantastic topics. We've had some fantastic lecturers and speakers, and we've really educated the industry across Australia and New Zealand, Singapore, Malaysia, Hong Kong, New Zealand, all the way across to the US and the northern parts of the UK. It's great looking at where everyone's coming from today. Well over 150 plus registrants for today. And today we've got an interesting topic. And we get a lot of questions in the lab, and no more questions that come in than in the splint department. How long do I wear a splint for before the TMJ issues start subsiding? How long do they need to wear a splint after the TMJ issues have been fixed? Is a day splint better than night splint? The questions go on and on. Does a flat plane splint increase the bruxing capacity, or does it do any long-term damage? How long should I be wearing a splint before it needs to be upgraded? And the most common question of all in the lab is, what do we do if the splint doesn't work? What happens to the TMJ? The occlusal splint doesn't help in servicing the jaw pain. And look, there's a number of ways of addressing that. But as a technician, we thought we'd go straight to the top and bring in Professor Michael Stubbs. So, Professor, look, I know that we've managed to talk you into coming and joining us again today. We do thank you. I know it's been a big year, and at the end of this, I'm going to hit you up for what you can do for us next year, if that's okay. But with no further ado, ladies and gentlemen, what to do when the occlusal splint doesn't help with jaw pain, Professor Stubbs?
Thank you. Thanks, Matt. As you know, it's always a pleasure to
Michael, we're having troubles hearing you. Maybe are you muted?
Let me see. Whoops. Here we are. Can you hear me now?
Still having troubles there. If I could, while you address that, if I could ask our engineering team, can you hear me?
Yeah.
You can hear both. Okay, Michael, you can be heard. I've just had the all clear to go on. It must be my computer, so please go ahead.
Oh, that's a relief. Ooh. Okay, so I'll get started, folks. This is something that I am really happy to talk about, because I do get asked this question a lot, when I give talks. And I suppose one of the things is, and it's really important to highlight here, is that when we're treating a patient who you diagnose has got temporomandibular disorder, it's not just about the splint. I mean, splint is one discipline. It's one element of the treatment. And so what I thought I'd love to do is just talk a little bit about some of the common questions I get asked, and maybe just explain a few things. Hopefully they're useful tips for you, and make it perhaps a bit of a smoother experience when you're treating your patients. So I suppose the first thing is, I gave a talk, it was like last year, on temporomandibular disorders and how you should treat them. And one of the things I did say was getting a good history is really important from the beginning. So asking those questions like, do they experience pain when they get up in the morning with their jaw stiffness or tightness? Do they experience tightness of the jaw, fatigue or pain when they're chewing their food? Do they experience ear block or ear pain? Headaches. How often do you get the headaches? Where do the headaches occur? Would you get them in the morning, or they tend to occur more as the day progresses? The relevancy of that is you can use those questions and the answers to those questions in the future when a patient says, I'm wearing the splint and nothing's happening, because you can go back and ask them what you asked them originally. So you've got a nice cross-referencing. Remember, people as human beings, we don't always remember what pain is. We are almost designed to forget it. I'm quite convinced that's why ladies can have more than one child, more than one baby, because, at the end of the day, we forget the realities of what pain we had. We might remember it was painful, but the absolute minutiae of what we experience when we experience is often forgotten. So having that kind of backup is really important. Secondly, you can see the questions I've written here on the screen. If someone says to you, I wake in the morning and my jaw is not stiff or sore, it generally tells you that the occlusal splint is working. And the reason I can say that is because often people who wear splints, and I say to them, do you wake in the morning with a tight or stiff jaw or painful jaw? And they say yes. We know splints can't stop bruxism. In fact, bruxism, as you know from one of the other talks I gave, is centrally driven, so we can't switch it off. I mean, yes, there are some drugs prescribed. I mean, clonidine, clonazepam, but to be upfront with you, I don't think any of us are really likely to prescribe those. What we are looking at, even Botox doesn't stop bruxism, but they're tools to use to reduce the symptoms. They're tools that we have available to us to help reduce, eliminate pain. And so asking that question, if they wake in the morning and their jaw is comfortable, it's telling you the splint is working. The problem is in that statement is that there are other things happening, which is why they're not getting better. If they find that their symptoms are worse during the end of the day, one of the things I would suggest to you is focus on strategies they can do to help themselves. It might even involve referring them to a specialist physio. It might be reinvigorating some of the jaw exercises, which I'll show you. It might be considering some simple medications that you can safely recommend. And I think the other thing too is that, as I said earlier, just remember that as human beings, we don't always remember exactly what the intensity of the pain was like. We just know it was sore. So the second thing, and I know I'm talking to colleagues here, but reevaluate your diagnosis. So have a look at the patient. I mean, you can see these series of photos here. This is a person who was diagnosed with TMD. They had a splint made. They obviously came back. They still had some symptoms. We re-examined their jaw, and you can see here we're palpating the masseter, we're checking the temporomandibular joint, we're seeing if there's any pain on the temporalis, we're getting an idea of what their range of mouth opening is. Remember too, in one of the talks I gave before, I said, measure the millimeter range of movement. 36 to 52 mil is a normal range of mouth opening. So if a patient started at 32 millimeters when you first met them and started treatment, and then you measure their mouth opening and it's 45 millimeters, but they've still got pain, it doesn't mean your treatment has failed. It just means there's more to do to help that particular patient. About 1 in 10 patients, in my experience, generally need pharmacology and other evidence-based disciplines such as specialist physio, but also reinforcing to the individual patient ways and means they can help themselves. Remember, we can only do a certain amount for the patient. We can't enforce that person to wear the splint. We can't enforce someone to go and see a colleague like a physio. We can't enforce someone to take a drug. What we can do, though, is reinvigorate that conversation to get the patient over the line. And so let's say, for argument's sake, okay, you've examined the patient, they've got some pain in their jaw, they've already shared with you a few of the symptoms they're experiencing, and they're saying to you that I'm not getting any improvement. Top photograph on the right-hand side, you can just see a couple of images of occlusal splints with various articulations. You can see the protrusive range. You can also see the centric occlusion range. I think one of the things important is always adjust the splints. Sometimes colleagues have an idea that when you fit the splint, whether it be 6 months, 12 months, 2 or 5 years, the splint, when they get it checked, I ask patients, I said, does your dentist check the splint? And they go, oh, yeah. And I said, what do they do with it? And they say, oh, they look at it. Well, I mean, we can all look at it, but, is that really balanced? I mean, is it really smooth? So honestly, I would highly recommend Arctic paper, like we know what to do, get them to slide laterally, have a look at the actual marks on the device too, because, you can often tell if someone's a clencher or let's say a grinder, because you can tell from the pattern of wear. So for example, if I look at a splint and there's these pinpoint crush marks everywhere, well, then they're a clencher. So I'm not going to get them with the Arctic paper to grind from side to side. I'm actually going to get them to tap up and down. And make sure it's even. I know it's a basic principle here, but it's a good one. The flat plane splints, in my humble opinion, are the best. I think the whole concept of a splint, as you know, is it separates the upper and lower jaw based on the thickness of the device. In my opinion, they work for lots of reasons. And one of them is it actually stretches masseter muscle. And I think it takes out some of the workout the jaw can do, but it doesn't stop the bruxism. So creating a smooth, uninterrupted, no interlocking of the dentition opposing and reducing some of the workout the patient does do, I believe is one of the reasons why splints help. You can see the photograph on the lower left. Now, that's a very nicely made nylon splint. I don't make many of them. I find, and I'm interested in what other colleagues watching this think, they're well made, they're not bulky, but they're actually, they're quite hard on the teeth. And sometimes patients actually complain because the splint is hard on the teeth. I like the acrylic style. I like the clear splint material. I know, Race, you make them, and you also do, Matt, don't you? Is it the Keystone? one you make as well. They're really good. They're the ones that you can gently run under some hot water. They're malleable. They're fantastic. And I think, just check the splint. And remember too, that, if you've seen the patient over a period of time, just always evaluate the occlusal wear on the device, recognizing that no splint, thank you, they're printed, no splint actually lasts forever. Most times we say about 3 to 5 years. But again, it comes down to how hard they're worked out. I mean, let's face it, we've all got patients who destroy them in 6 and 12 months too. And I suppose one of the talks I gave was looking at bruxism and the severity of it and thinking about other underlying causes. Remember, we talked about medications in one of the previous talk. We talked about sleep apnea. I won't go into that today. We've done that. But I'm just thinking this is one of the simple things you can do to determine why isn't the splint perhaps helping. The other thing is you can see photograph on the top left-hand side, just the flat plane splint that I used articulated on the model. The one on the lower right is more showing you that sometimes what I do is if someone's got an occlusal splint and they're wearing it, but they're still waking up with a stiff or tight jaw, you can increase the occlusal vertical dimension. Now, I realize there's different schools of thought about this, but from my school of thought in oral medicine, we do build up the posterior blocks. And so what we would do is you can see the gloved technician here working on the splint with some acrylic. But you can see, if I can use this as an example, you'll see how there's posterior blocks from 4 to 7 and no contact across the anterior segment 3 to 3. Now, I know some of you are going to see that and say, hang on a minute, those lower incisors can over-erupt. Interestingly enough, it doesn't tend to happen that much, if at all. I mean, it does happen, but these are just one of the standard type devices I use routinely for patients that are quite profound bruxes or present with quite significant jaw pain in the morning. And again, remember, we can't stop bruxism, but biologically, when we're stretching masseter muscle, in my view, we are reducing how hard the mandible opposing the maxilla works. And I suppose one of the other evidence-based disciplines is pharmacology. Now, as dentists, I put some medications up here, which I appreciate everybody watching is comfortable to prescribe, but you may not necessarily know what's out there other than, say, Nurofen. And Nurofen is just a brand name of ibuprofen, but we've got Voltaren, which is diclofenac acid. Again, different brand names. In the Voltaren or diclofenac, 50 milligrams is a good dose, sometimes once or twice a day, but with food. The ibuprofen is not bad. It's, again, useful combination with paracetamol, which you can see here on the left-hand side of the slide. I've got Maxigesic. That's a very well-known medication that people can pick up from the chemist. Again, no script required. Naproxen does require a script. I find naproxen is fantastic. You know, when you get those acute TMD cases where they've got severe pain and they come in to see you, they can take a 500 milligram tablet of naproxen morning and night if they need to, again, with food. And it is a really effective anti-inflammatory. So if you get a case, let's say, where there's trauma, imagine someone's yawned or they've sustained a blow playing sport, you've got an acute TMD, you know there's a lot of inflammation in the joints as well. Naproxen is a knockout. It's a really good one to go to. And again, as dentists, we can prescribe them. This is one of my little pet favorites, Norgesic. Now, Norgesic or Norflex is orphenadrine citronate, and it's actually, or phenadrine citrate actually, it's actually like an antihistamine, but it's not. In other words, it's a lousy one, but fantastic muscle relaxant. I like it because it's non-addictive and, generally speaking, non-sedating. If you prescribe Norgesic, because it doesn't have codeine in it, what you need to do is recognise that, the Norflex doesn't have codeine in it, Norgesic does, but with what you need to do is recognise that if your patient is breastfeeding or if they're pregnant or if they have glaucoma, using Norflex or Norgesic is contraindicated generally, because with breast milk, it can pass to the baby. There's not enough studies to validate the safety with Norflex and pregnancy. And like anything, everything in moderation. And the Norgesic generally people take during the day. It's about 30 milligrams of the Norflex, whereas 100 milligrams you prescribe at night. That's the standard dose at night time for Norflex. And again, most patients will wake in the morning feeling quite refreshed. They don't feel hungover or tired. You might remember there was another antihistamine, doxalamine succinate, very familiar with Mesindol. Now, Mesindol requires a script because it's got codeine, but if they go for Restovit is a brand of just the antihistamine, 25 milligrams over the counter. You can recommend that to your patient. I strongly suggest if you're going to do that, get them to break the tablet in half and start with 12.5 milligrams because it can be quite sedating. Again, why are we talking about these? These are cases where patients are still having pain despite using the splint. So you might look at, say, something to enhance the relaxing of the jaw at night. People sometimes say things like, oh, when I wear the splint at night, I find I'm actually grinding or clenching a lot more than I used to. In fact, I believe it's because they're more aware of it because they've got something in their mouth. And I also encourage patients to say, look, if you're one of those people that say they wear their splint in the night, they go to bed, they wake up in the morning, the splint's not in the mouth and it's thrown across the other side of the room, and then we've all got those patients, then I highly recommend get them to wear it during the day at different times. But I think the other school of thought which exists is the view that you should have a day and a night splint. Now, again, I can only speak as a oral med specialist and also as a fellow of the Australian Academy of Oral Medicine and Facial Pain. We don't recommend day and night splints. I think one of the problems you have is you don't want to create a situation where the patient cannot function without a device in the mouth. That's not quite the desired outcome. So if someone says to me as a patient, can I wear my splint during the day? I'll often say, well, you can, but you might wear it, say, driving, or you might wear it if they go to the gym and do weights, or you might suggest if they're working in the office. In other words, different times where there might be a link with tooth clenching or grinding of their teeth, but not necessarily a day and a night time 24/7. I highly recommend against it. Patadine Fort we're all familiar with. We all take teeth out. We understand the value of that. And Valium, 5 milligrams, is a good one. Folks, if you ever get a patient, let's say you're given a block, mandibular block, and they get trismus, put them on 10 milligrams of Valium. And you can get them on 10 milligrams at night. And you can also, dare I say, maybe start them at 5 in the morning, 5 milligrams in the morning. And that you might do that for 3 or 5 days to really relax the muscles, because you know the medial pterygoids go into spasm if the needle strikes through, particularly if you've injected into the medial pterygoid muscle. For TMD, I generally only prescribe 7 tablets. The box you can see here on the left-hand side of the screen comes in 50 tablets. Just prescribe 7. We all know that diazepam is a useful drug, but also we want to create a situation where we limit the amount of available drug the patient has, because the treatment is not just about pharmacology here. You're using it as we might say, an adjunct. In other words, in addition to what you're doing already with the splint. And jaw exercises. I mean, this great looking photo here is it's based on the Roccabato technique, and the tip of the tongue on the nasopalatine papilla, very gently and slowly. The patient opens their mouth to the length of the tongue. They hold. That's it, Matt. Count to 20, and then they relax. Now, the really interesting thing about this exercise, and of all the exercises that exist, I have to tell you, this is the one that I always recommend because, A, most people do it. B, you can do it driving the car. And people that live in Melbourne and Sydney, and I'm sure other big cities of the world know what it's like driving in a major city. It's nice to relax the jaw. Your tongue length is the same length all your adult life. So every time you're opening, holding, and counting to 20, your temporalis and your masseter muscle actually switch off. So it's a really useful one. And I don't give numbers. People say, how often should I do it? Well, I don't say do it 10 times a day or 15 times a day. I mean, my thinking is that's academic. How do we know the difference between 5 times a day and 20 times? Does that mean 20 times a day is better as far as results? Probably not, because the patient's more likely to stick to a few a day than doing deliberate numbers, because we all get bored and tired of doing it. So I always advocate every time you get behind the wheel of the car, do about 2 or 3 in a row, and you might do it on the way to work. You might do it on the way home from work. You might do it before you go to bed at night. Easy. Second one is the same exercise as the first. The tip of the tongue is on the nasopalatine papilla. You can see the fist here, what can be the hand. The idea is that as you're opening your mouth, you're pushing against the hand, so you're getting more resistance, particularly in the masseters. That's not a bad one. It's one that I don't often use that much for patients, but that one is not a bad second. And the third one is just the teeth apart slightly and putting the hand or the fist on the chin and push the chin into the hand. So, for example, as you can see in this image, pushing like that, count to 20, relax, do 3 of those in a row, and then do 3 on the other side. Very simple, very practical, and it works on different muscle groups. So again, your patient saying to you, my splint's not doing enough, I've still got pain. You can say, well, hang on a minute. Are you doing the exercises that I showed you? I can prescribe you some simple medicines to help speed up the recovery. And there's a similar view on the other side. And physio. I mean, how many of you have ever referred patients off to specialist physios? They do exist. There's not many, granted. But even at myotherapy, sometimes chiropractor, osteopathy, I think at the end of the day, we know in the academic world that physical therapies are very useful modalities for treatment of TMD. Again, the focus is more about the individual learning what to do during the day. Remember, the splint is more for nighttime use. It helps reduce the workout of the jaw at night, if you like, but it's not the only treatment that they necessarily should have. Botox is very popular, and I know some colleagues really like using it, and that's fine. We're all colleague educated. We all choose what we want to do. I don't normally advocate for Botox unless it's one of my go-tos when other things fail. So Botox is a useful treatment. I've just put here, roughly speaking, the muscles have certain amount of units that you can capable of doing for Botox. So you can see temporalis is about 10 to 25 units per muscle. Masseter is about 25 to 50, based on the references I've just put down below. Again, Botox doesn't stop bruxism, neither does a splint, but it is a useful condition, particularly when you get those patients to say, look, I don't want to take a muscle relaxant, and I'm allergic to everything. And we've all got those ones as well that tell you they're allergic to all medications, which always intrigues me because I say to them, well, you obviously tried them all. So I think basically using them, Botox is a useful discipline. Again, for me, it's one of those ones I tend to go for last. Other colleagues like to do it first. May I suggest try a splint before you do the Botox though, folks. I do appreciate the value of Botox as a treatment. It is expensive. We all know that. And may I suggest too that a splint is something more conservative, more sustainable than jumping straight into Botox as your first line of therapy. But, we're all educated colleagues and we do what we believe is right for our patients. And I think the last thing, which is the obvious thing, reassess the diagnosis. You can have a patient successfully treated for TMD. They might come into you, and we've all had them, where they've suddenly got acute pain and they say, look, my treatment's, it's got worse and nothing's helping. And we always assume that it's still the TMD, but we know, there can be other causes. And one of them is it dental. So, for example, you can see here on this really great image of a CT, we've got an abscess developing in the tooth. So yes, the patient had TMD, but they also had a dental abscess. And one of the things we know too is that when the mandible is involved, mandibular teeth, often the pain radiates up to the ear. And often when the maxillary teeth, particularly posterior teeth, are involved, often patients talk about temple pain. So again, you can palpate the structures, you go through your process of elimination, and always view changes in symptoms with fresh eyes. Don't always assume that it must be the same condition and what you're doing is not working. It can be other conditions, as you can see in some of these images that I'm highlighting on the lower right and middle left of this slide. And sinusitis. Sinusitis can mimic TMD. I mean, patients can talk about headaches. They can talk about pressure around their eyes, blocked ears. They can have facial pain, particularly aching quality. And again, CTs are great. They're almost the gold standard for making the diagnosis. You can see on the left-hand slide here, you can see the maxillary antrum here is completely obliterated with mucus compared to that on the right. So again, a classic symptom for that would be someone saying to you, I don't know what's going on. I put my splint in at night. I lie down, and within half an hour to an hour, I'm getting up and I'm pacing the floor to get some sense of relief. Think sinusitis. Again, we touch the face. I realise you can actually demonstrate pain in some of the regions, and also understanding TMD can mimic sinusitis. So again, always review the changes in the symptoms with fresh eyes. And here we can see again a rather nice image with the thickened mucosal lining of the antrum here on the left side. And cranial arteritis, fortunately, not common. But if you get a patient that says to you something like, I'm finding that when I chew my food, my jaw gets very tired, very sore. Naturally, we would assume, wouldn't we? It's temporomandibular disorder. It's a very reasonable assumption. But those patients, particularly, let's say the elderly, one of the things is if it doesn't seem right, like for example, if you palpate the masseter muscle, the TMJ, and there's no pain on palpation, one of those little voices in the back of your head that says, think about other things, a blood test looking for what we call ESR, erythrocytic sedimentation rate. It's a non-specific marker of inflammation. Normally in men and women, if I said to you normally below 20 is the normal, in someone with this inflammation, which is where you can see on the left-hand side of this slide, this is the temporal artery that's been biopsied, and you can see how narrowed it is because you've got these giant cell inflammatory changes in the lining of the vessel. So obviously, like the heart, when the vessel's narrowed, as the muscles start to work, they get ischemic, they get less blood flow. And so they can mimic TMD. But patients will often say, when I stop using the jaw, the pain goes away quite quickly. And again, they're the ones that you just do a simple blood test to see if cranial arteritis is there. It is something that is, you can see here, affects 5 out of, say, 10,000 people. That's based on US data. But it's particularly where you get tenderness on the scalp, and particularly an older patient, let's say someone over 60 or 70. It's just one of those things to think about. And rarer conditions, I realise, is tumours. This photograph on the right-hand side, this is a very large squamous cell carcinoma. What's interesting is the patient developed the tumour, but they actually had pain that radiated up into their ear and to the back of the jaw. And so again, it can mimic TMD type symptoms. I realise, like most of us, you get them to poke your tongue out and you'd have a look. And so hopefully this wouldn't have been a surprise. But let's say, for example, in a case where someone presents with symptoms of sore jaw and you're doing your assessment, always obviously evaluate the soft tissues. And when you get symptoms like paresthesia and anaesthesia, that's a concern. Now, we know with TMD, from one of the talks I gave previously, you can get these altered skin sensations we call dysesthesia, where people say, oh, my face feels tingly, I've got insects crawling on the skin. That's not an unusual phenomena in TMD patients. But it's when someone says, my tongue is numb or this part of the jaw is numb, and particularly if you get a sharp probe and you jab it and there's absolutely no sensation, high suspicion of compression of a nerve. And in particular, you can see here in this photograph that the ulceration at the base of the tongue via the auricular temporal branch of the mandibular nerve actually can give the ear symptoms. And this is one patient I had this year, actually, where she actually presented, and I did an OPG, she had a non-healing ulcer at the back and she had jaw pain. But going through her medical history, she'd already had renal carcinoma. And sadly, that highlighted area there on the OPG was a secondary renal carcinoma. So, not a good outcome for the patient. But again, the mimicking of jaw pain. So always just reevaluate, I think, is really what I'm suggesting. And always remember too, that at the end of the day, if your splint's not working, it doesn't mean your splint has failed. It's about looking at dimensions of the splint, vertical dimension, checking that it's even, and also ask the right questions. Does the patient wake in the morning with a stiff or sore jaw? If they don't, and they're feeling pretty good, I think it's a fair call to say your splint is working. It's other causes, other things you need to introduce into the treatment. Thank you.
Michael, once again, thank you. Your way of simplifying information is fantastic, and no doubt we all get a lot out of it. I've got a bunch of questions to run through.
Yeah, fire away.
Could you run us through the pros and cons, in your opinion, of upper versus lower splints?
There's no difference. In fact, interesting, it's a good question, actually. There is no difference. What I do is when I make the judgment about it, I'm often looking at other factors such as the opposing teeth to the splint. You want as much tooth contact as possible. So let's say, for argument's sake, the patient's got a reasonably full complement of maxillary teeth and they're missing their molars on the mandibular. Then I'd make it on the lower because you've got to get more contact. The other thing I look at is if there's tongue trauma. So you know how sometimes patients bruxing, they irritate the edging of their tongue. There may be thickening on the edges from that trauma. I'll make the splint on the lower to try to protect the tongue. The issue, and the reason I prefer maxillary splints as a general rule myself, and when we did oral med, we were trained to make them mainly on the mandible, is often patients sometimes bite their cheeks with the mandibular splints at the back. So you've got to make sure that the occlusal table is a certain width. Whereas with maxillary splints, you don't tend to have to worry so much about it. So generally, I make maxillary splints, but honestly, there is no difference in outcome between either.
Okay, and on top of that, Michael, if I may add, no doubt the most requested splint here, upper versus lower, is definitely the maxillary splint, probably 60-40 or more. So if that gives anyone a bit of idea what the rest of the industry is doing, that's what the lab's being received. I tried the nylon splint I tried the nylon splint, but my patients complained they were too hard. What material would you recommend for comfort?
Look, well, the 3D printed ones, like Race, you make Race Labs make the Keystone one, and also there's the clear splint material. I just love those materials because one of the things about them is they're not bulky. And even though they're rigid, you can run them under a little bit of hot tap water for about 20 seconds. It softens and it molds onto the teeth. So you get better compliance because you don't get that excessive tightness on the teeth, which the traditional, methyl methacrylate ones we used to make or have made, where they were really tough on the teeth. And so patients would sometimes say, I can't stand the pressure. The other thing is Michigan splints are really good too. I haven't really talked about those. It's just that I have a preference for flat plane. But the Michigan is a good one. I just find that with the Michigan, sometimes you just got to watch lip seal with the ramp at the front. I mean, sometimes patients complain they can't get their lips together. But other than that, Michigan splint is a good one as well.
Okay, well, Michael, yeah, there's no doubt that our fastest growing product ever launched by Race has been our printed splint because they fit like a hard, soft splint. Being thermosensitive, they get more comfortable in the mouth over time, and you get to the habituation stage much quicker, so they disappear in the mouth. And they're easier to get out because they're thermosensitive, but they act like a hard acrylic splint, but they're as comfortable as a hard soft. So we can no doubt see why they're our fastest growing product.
You know what? Compliance is everything. And if that splint is comfortable, they wear it. And if they wear it, you get the results. So that's the beauty of that technology.
Yeah, for anyone that's interested, if you like that splint, just request the printed splint and you'll get that AI designed printed splint back. Michael, the next question, if I could move on. Would you recommend a splint after full arch crown and bridge reconstruction? And I'm not sure if they meant if they were maintaining the occlusal or vertical dimension, or if there was a change. Maybe you could touch on both.
Yeah, look, I think it's a good question because I think, again, it's reasonable. One of the things you do worry about, don't you, is the bruxism and whether there's going to be failure of the porcelain. And we know that, for example, certainly looking at some studies on bruxism, which I talked about in one of the talks, it demonstrated that mechanical failures of restorations and teeth can be attributed to bruxism. And so I think it's a very reasonable thing to maintain protection of the work because a splint's replaceable. The patient bruxes through it, you just put another one in. The other thing is too, with the vertical dimension element, again, if you're, let's say for argument's sake, having someone that's got significant jaw pain, that's when I go for the slightly greater occlusal vertical dimension. So one of the things I usually work with, let's say, is 3 millimeters interocclusal distance. That's what I generally tend to go with. But when I showed you the slide there earlier of the build-up, sometimes in those cases, I might build the posterior blocks up to 5 mil, 6, 7 mil. Sounds a lot, I know. Dare I tell you, I've got about 10 patients, 12, which is unreal, but that's the only thing that worked. So, again, it's just using your judgment, but I'd never start somebody at 5 mil. I'd always start them at 3 with the flat. And the beauty of the flat plate is you can add material to it. And the printed ones, you can do the same. So I just do cold cure acrylic and I build it up on my articulator of the patient's models with the splint on the model. And I can actually create the height that I'd like, the vertical dimension, and then just cure it, polish it, trim it. And then when I fit it in the mouth, I just smooth to make sure that the posterior blocks engage all the posterior teeth on the opposing arch.
Oh, wonderful, mate. Yeah, most definitely approaching it slowly so as not to traumatize the patient up front, I'm guessing.
Yeah, and also it's not too bulky. Yep.
A question that we get in the lab a lot, and one that I have troubles answering. I'm not sure if it is, if there's a stable question or a straight up answer to it, but the question reads, if the splint works in helping jaw pain, can the patient stop wearing it?
Yep, you can. They can. What we generally do is, as a rule of thumb, I say, look, I encourage them to wear it every night if they can for at least 6 months. So obviously I would review the patient. Now, when I fit a splint, I usually see them about 3 months after they've got it, unless they're having problems getting used to it or there's some issues. And then I start making judgments on the frequency of the review visits based on the amount of adjustment I've got to do. In other words, is there a lot of bruxism mark, a lot of unevenness, or is it actually not too bad? And also there's symptom improvement. 1 in 10 patients will always want to wear the splint every night, and they can for the rest of their life. And the reason that we make that judgment is they're the ones that find when they don't wear the splint, they get the pain. And it's almost like biologically, I think the height of the splint when they wear it, that change in vertical dimension is the ideal biologically for them. Now, I appreciate one view might be, well, if that's the case, why can't we build up the occlusal surfaces of the natural teeth? Well, you could. But it doesn't, again, the patient would still, I would think, wear some device to perhaps prevent wearing of the build-ups. And so I think it's so much easier just to put the splint in. So 1 in 10 on average will wear it every night for most of their life. 90% of patients by 12 months only wear it when they need to. And part of treating the patient with TMD, I often say to them, when you notice that there are changes happening, you're starting to get some relapse of your symptoms, you say to yourself, what exercise did Michael teach me? Maybe where's the Norflex or the Norgesic, and where's my splint?
Oh, that's interesting. Michael, I'm thinking of cross-pollination of departments here at RACE, or even multidisciplinary approach clinically. Can a splint be used as a retainer?
Yes, absolutely.
So
and a splint, yeah, absolutely. And you get those cases where severe bruxism, severe tooth loss, and you're planning to say restore the vertical dimension, the occlusal vertical dimension. Often I encourage the splint to be used with the height that you want, so you can actually determine if the patient will tolerate that vertical dimensional increase before any restorative work is done.
Kind of like a third introduction of an orthotic.
Yeah, that's right. Absolutely.
Okay. Look, well, before I throw you under the bus, Michael, and ask you to finish on one most important piece before I leave, for those dentists watching in New Zealand, we've got great news now. We've finished building our new lab over in Grail Inn in Auckland, and Booba and her fantastic team of technicians and administrative team over there are awesome. And there's one technician particularly called Staver, who I'm most impressed with the capabilities of the acrylic technician there and his team. So by all means, call Booba and her team over there and ask for Staver. He's a wealth of knowledge. He knows all about these splints, your acrylic work and all the rest of it. So lean on the lab, especially the New Zealand dentists over there. Feel free to lean on Booba and her team. They are a very strong team. It's a beautiful lab. So if you get the opportunity to send some work there, by all means, go ahead and do that. I believe I've been told now that the annual CPD cycle ends on the 30th of November for the clinicians now. So by all means, jump on racedental.com.au and go to the EDU or the education section. Click on the topic that you wish to watch the topics on demand. Michael Stubbs is there with a whole bunch of topics there. There's a wealth of information there. Once you've watched it, click on request your certificate and you can maintain your CPD recommendations or requirements. And don't forget that is required by the end 30th of November. So keep that in mind. But Michael, as usual, I'm just checking there's no more questions. Is there anything you could leave us on in your recommendations in regards to the occlusal splint and reducing pain?
Yeah, I think the take-home message is with a splint, obviously not every person with TMD needs an occlusal splint, but those that you're making them for, always make sure if you can to make them not too bulky, and also always educate your patient on the fact that when they come for their review visits with you as part of your dental care, get them to bring the splint, but please don't just look at it. Put it in the mouth, put our tick paper on there, polish them up. They work better when they're smooth.
Thank you, mate. I again thank you. The questions are pouring through. I do have one more minute. And Ronald has just said, thanks for an excellent presentation,
Thank
mate. I'd like to reiterate that. Ronald, for your sake, you can go onto the Race Dental website and watch under the educational sections, the on-demand videos. And at the bottom there, you'll see a button to click to request an email request your certificate for CPD purposes. So by all means, go on there, watch what you need to, and request your certificate for CPD. But Michael, again, your wealth of knowledge. I know this wraps us up for the year, but the Race Academy would love to extend the invitation for us to join us next year. We do have a plethora of questions and clinicians who would benefit from your education. So can I put the hand out and ask you next year?
Absolutely. Look, I love being part of this. It's engaging. I enjoy it, and it's well organised too, I have to say. And for those folks where I couldn't attend the last year, and I do apologise for that, we had a technical hitch, but I'm very happy to continue, and I'm thinking of some really interesting topics for next year already, which we can announce perhaps next month.
Well, I'm most looking forward to that. I've noticed our marketing team here, and I'd like to thank Marissa for what she's done here in putting all this together. It's a wealth of organisation. It's a big job putting the teams together. I know the topics are coming in for next year. Michael, we're glad to have you a part of it. We've got some real exciting new speakers, some university lecturers joining us at the Race Academy next year. So I'm looking forward to seeing everyone then. Put your head down, pin your ears to Christmas, stay safe, and we look forward to seeing you all again. Professor, I appreciate you again. Thank you. Look forward to seeing you next year.
Thank you, Matt. Much appreciated.
All right, guys. Thanks very much. Stay safe.
Bye.
Next year. Take care.
Thank you. Bye.